This is Dani Farris, and I'd like to introduce myself. I have a Master's of Science degree in nursing, and I also am a psychiatric nurse practitioner, and I work at a university student health center. Many of my students are very anxious when they come in, and I would like to do an immediate intervention for them. And so my presentation is called Diaphragmatic Breathing as an Immediate Intervention for College Student Anxiety, and it's a quality improvement project rather than a research project. And I just wanted to let you know that research has to do a lot with making sure that we better things, but not as much as quality improvement. Quality improvement is a great thing within medicine where we take an issue, we examine the issue, and we try to improve the outcomes by changing an intervention. And so this is an intervention that I would like for us to consider today. Stress and anxiety is a worldwide collegiate problem. And stress and anxiety in the United States in the collegiate population happens to be that, let me give you some statistics. In spring of 2020, the U.S. National Collegiate Health Assessment reported that out of 50,000 respondents, 74% of them reported moderate to high levels of stress and anxiety. And up to 27.4% were treated for anxiety disorders. That's a pretty significant amount of those persons, of 50,000 respondents. And then it noted that collective respondents reported that stress and anxiety had the greatest negative impact on their academic performance. These issues were greatly increased with the demand for on-campus mental health care. It's pretty interesting when you're on the university campus how you're starting to realize the more people that come in for these stress and anxiety issues need to have extended care, and the demand for that extended care is so limited. So collegiate anxiety on the global scale. So the World Health Organization in 2018 reported that anxiety in this population is continually increasing and is greatly affecting the attrition and social problems on our campuses. And as we know, our main goal on campus is to help our students to be able to get through the programs and to graduate. And this is actually thwarting our goal. Not only that, it's really causing a lot of issues with interpersonal problems as well, which our students then become, they start to have feelings of isolation. This report from the World Health Organization also noted that the severity of anxiety is worsened by these limited mental health resources throughout the globe, because they're not able to have some kind of intermediate treatment before those mental health resources are available to them. As far as my university campus is concerned, 95% of the providers at the health center, their student patients, have to wait an average of 6 days to a few weeks for an appointment with a mental health care provider. So a specialist in mental health care, whether it be a primary care provider who's providing mental health care or the counseling services that we have to offer. So short-term anxiety relief is severely needed in order to improve immediate treatment outcomes for our student patients. It is noted that the onset of anxiety disorders often occur in the college age individuals, And early treatment can have a preventative effect against further mental or physical illnesses. This information is part of what motivated me to improve the quality of care at our Student Health Center for those students that were experiencing acute anxiety. So my quality improvement project aim is to determine if a standardized breathing exercise is going to lessen acute immediate anxiety symptoms until a mental health care provider appointment is available. And my goal is to discover if that immediate intervention, which I am choosing to study diaphragmatic breathing, or explore diaphragmatic breathing, standardized by the use of a mobile application called Breathe to Relax, which was actually studied. It's an evidence-based application, mobile application, that was actually used or was created by the U.S. Defense Department for those persons coming home from war veterans, and those persons who had been home for a while who were experiencing PTSD and really intense anxiety. They created this application to help them to be able to immediately relax and take them out of the moment that they were experiencing. And so we did not choose just any mobile application. We actually chose an evidence-based application. And what I wanted to do was to see if using this application as more of it helps to create standardization of diaphragmatic breathing exercises so that everybody is practicing the same way, the same exercise, instead of trying to look at the variables. And so we wanted to see if diaphragmatic breathing is an effective immediate intervention for treating anxiety symptoms. And I wanted to compare the before and after screening scores, as well as subjective reports from the participants concerning the effectiveness and experience following the implementation of diaphragmatic breathing exercises. A comprehensive literature review was completed using the Cochrane Library, CNOL Medline, PsycInfo, PubMed, and Google Scholar. Articles from 2016 to 2021 were the only ones that were included. 10 studies resulted and all supported the use of diaphragmatic breathing exercises to improve anxiety, especially for those over the age of 18. It was not specific to collegiate population. However, it was specific to the age of the persons who are within that collegiate age range. And of those persons in our project, we did not consider those persons as eligible to be participants if they were under the age of 18. 2 of these articles reported that significant improvement was seen in symptoms with use of different mobile applications, and one of the reviews reviewed specific applications that supported the use of evidence-based application Breathe to Relax, the Breathe to Relax application. The great thing about it is there is no cost to it. It's also available on computer if the patients were participants were unable to afford cellular data. They would be able to go to the library or to their laptops. Anyway, it's computer. It's available on the computer as well, so they don't only have to have data that they pay for. Looking at frameworks that I based this specific study on, I wanted to first note the Plan, Do, Study, Act model. This study, or this project, actually has a really small sample size, and this model supports a small sample size for the initial cycle. This is actually a cyclic model, and so as each cycle continues, it includes a wider and wider versatile persons that are involved in all of our system, and all the care providers and student patients who are included in sample sizes as we move forward. It also provided a framework for integrating and evaluating the effectiveness of our intervention. It included the whole disciplinary team that I have. I am the only mental health care provider that is specifically trained for that in our clinic. I, however, am only able to work a limited number of hours, and so we depend on other persons to provide this type of care as well. 3 primary care providers, one of which is a physician's assistant, and 2 of them are medical doctors. They actually, as well as other supportive team members, are really important parts of the team, and we needed to have buy-in in order for this to work effectively, and this model supports that very strongly. It also provided a framework to guide reaching the goal of repeating integrative, like I said, the integrate or continued cycles to slowly allow the spread of the intervention as it's integrated in practices throughout all the care providers in the clinic. That's the goal. However, we just want to make a small step at a time, continue to gain buy-in, and continue to integrate our care in wider and wider and wider circles as we complete each cycle of the Plan, Do, Study, Act model. Then the clinical practice model, the clinical practice model aims to continually improve collaborative systems, and it leads to team communication and discussions. It provides problem-solving planning from multiple perspectives, and it allows contributions, or it contributes greatly to buy-in and the whole system change, which goes hand in hand with the Plan, Do, Study, Act model. The Plan, Do, Study, Act allows things to move slowly and allows for multidisciplinary team members to buy in. And then we look at the clinical practice model that comes together, and again, collaborative systems. And we're trying to greatly improve the ability of buy-in, and that eventually we're going to have the whole system change. Let's look at the methods that I used in this project. In our sample, we actually had very culturally diverse patients. We had patients of different ethnicities. We had patients of different sexual orientations. We had persons who were culturally diverse, like they were from different countries and different religions. And however, these persons were this sample was only drawn from my patients. With those persons who had complaints of anxiety or generalized anxiety disorder 7, GAD 7, which is a screening score for generalized anxiety disorder, greater than or equal to 5, which really supported at least minimal anxiety that affected functioning every day. Initially, I had 76 recruits, and of those, 26 persons became participants, and there was a significant amount of dropout, and we'll talk about that in the future, but I really think that it was related to a lot of this COVID-19 restrictions that I had, where I had to just deal with persons over email, over telephone, and it was, I think, very limiting. and really affected the amount of interaction we had, the quality of interaction that we had, and affected, I think, the dropout. So it ended up with 16 participants that completed the project. The setting, again, was, like I said, telehealth, related to the COVID-19 pandemic. And it was conducted through the Student Health Center. And that Student Health Center, we serve 16,600 university students per year, approximately. However, many of these students do not access these services, and I have such a limited amount of space for student patients that when we're drawing from just my patients, it's a very small population that we're drawing from. So what I wanted to note was also the setting is that healthcare, or the Student Health Center staff, included direct care providers, support care providers, even x-ray, lab, pharmacy, and central support persons. It's a varied, extremely varied care facility. And I really would like to see this type of care coming into all areas eventually. And so our tools that we used were the GAD-7 screening, which has 95% sensitivity and 95% specificity to measure the severity of anxiety. The great thing about it is, for our students and for us as well, is there are no copyright costs. And it's available in over 80 languages for those persons who are culturally diverse. And so as far as the information collection was concerned, this is kind of the process, is that I collected data from October of 2020 to December 2020, so approximately 8 weeks. The recruitment and communication was completed by telephone or email, like I mentioned earlier, related to the pandemic restrictions. Initial questionnaire was submitted by 26, and the final questionnaire was submitted by 16. So, as I noted before, I think that the reasons for the dropout rate may have been related to the lack of face-to-face content. Surveys were actually, before I go down further, I'd like to really mention the fact that the initial questionnaire was submitted by 26, final questionnaire was submitted by only 16. So therefore, in the study, I only considered persons who did both the initial and final questionnaires, because I needed both of those scores in order to get my information to be able to base this further cycles of this this project. And so 26, although 26 answered the initial, we only went with the 16 answers that were both initial and final completed. Okay, so back down, the surveys were emailed weekly with a personal note to maintain interpersonal connection as best as I could. And throughout the process, it's uncertain how this affected the dropout rate. My goal was that by sending out weekly surveys instead of just one initial survey and then 8 weeks later a final survey, was to really keep these persons connected as much as I could to the project and to myself, so that we could actually hopefully keep them really, I don't know, interested in the part that they played in this project. So like at the end, it says only participating persons that were completing the initial and the final questionnaires were eligible for final consideration. The process: participants were emailed a weekly survey which included the GAD-7 screening, a request to note the number of times that the intervention had been completed, and a request for subjective information concerning the effectiveness of the intervention. It was really interesting because the survey was quite short, but at the same time, some of the answers, it was a great eye-opening experience for me to see, to have the information from a subjective, open-ended question about the effectiveness of the intervention and how the intervention affected them personally. And we'll look at some of those results later, but I think that was a great way to approach it for those of you who may be interested in doing some improvement project in the future. So the project duration was 8 weeks, and the participant responses allowed for comparison of pre and post GAD-7 screening scores, and those scores were compared to the number of times that the intervention was actually completed. We also reviewed the subjective experiences that were noted. So I wanted to look at the process map. A student presents for a mental health care visit by the psychiatric mental health nurse practitioner. The GAD-7 is administered and mental health assessment is completed. If the GAD-7 scores were less than or equal to 5 or no complaints were made of anxiety, then the screening was complete and we proceeded with the psychiatric mental health nurse practitioner visit as scheduled. However, after administering the GAD-7 and the mental health assessment was completed and we found that the GAD-7 scores were greater than 5 and or complaints of anxiety were given, then we proceeded with the visit and initiated appropriate treatment, obviously, and referred to campus counseling services or other services that may have been needed. And then I recruited for the project. I taught, if they wanted to be a part of the project, I taught them the diaphragmatic breathing exercise. I helped them with downloading the mobile application, Breathe to Relax, and showed them where the tutorial was there and asked them if they would like any more education on that. And some of them did and some of them did not, but we downloaded it at that time and made sure that they understood how to use the application. And that was as an immediate intervention, hoping that by giving them some kind of exercise to do immediately, that they would be able to have some soothing exercise of some kind, to be able to feel like they were empowered and able to do some of this on their own. And we also then scheduled them for a follow-up appointment. Just to give credit where credit is due, the weekly surveys were distributed via Qualtrics. And then at the end, the Qualtrics information was downloaded into Microsoft Excel for further evaluation because I was more familiar with that software. As far as the results are concerned, comparison of the pre and post GAD-7 scores revealed a greater improvement related to the frequency that the intervention was completed. The final questionnaire revealed that 81% of participants, so 13 of the 16, expressed a subjective sense of improved anxiety symptoms following the completion of the intervention. That's a pretty high percentage. And you can see on the graph here how those persons who had an initial score plus an intervention frequency of 1 to 5 times per week, so they were a lower frequency. You can see in red what their initial score was, and then in the blue following, you'll see what their post score was, the final score. And there were only 5 participants who actually only completed the intervention 1 to 5 times per week. And then if you'll notice the green versus the blue, this is an initial score of those persons who did the intervention 5 or more times per week, and all of the blue is the final scores. So the green are those persons whose frequency was 5 or more, that's their initial score, and their final score. And then the red is those persons who later completed the intervention 1 to 5 times per week. And you can see the significance that the more the persons completed the exercise, other than one outlier here in the middle, everyone saw a large improvement in their anxiety levels. And again, down here we're talking about the questionnaire. The final questionnaire revealed that 81% of participants expressed a sense of improved anxiety symptoms. And then when we get down here to the bottom bottom evaluation, it says the answers to the open-ended question really kind of surprised me and yet didn't surprise me at the same time. It said specifically that the intervention was effective immediately, as we wanted, right? But that the results didn't last very long. So the intervention had to be repeated in order to reach best results. But they were still able to reach the best results because they already understood the intervention and how to do diaphragmatic breathing exercises. They were able to complete them at any time, anywhere, which was a great positive, is that it was not something everybody else could see, but they could actually complete it in class and other places. So the results were pretty impressive. And then the conclusions were that Collegiate students are often expressing a sense of intense anxiety, as we know, and that stress doesn't include just affecting the quality of life, but their academic performance as well, and attrition rates for those of us who are on the other side trying to help them get through school. And it's not only a local issue like it is for me, but it's also a national and global issue, as we discussed earlier. And considering the widespread issue and the limited on-campus mental health care resources, you can see that because these students are needing to wait days to week to get assistance from these other mental health resources, there's a great need for an immediate intervention to assist with the treatment of anxiety symptoms while waiting for mental health services. The intervention of diaphragmatic breathing, guided by the mobile application Breathe to Relax, we've found to be an effective immediate treatment. And although it has to be repeated in order to remain effective, it's something that students are clearly seeing an improvement for. And so the next goal is to make another circle of the Plan, Do, Study, Act, add more people in, and at our local student health center, we would like to bring in the other persons or providers who provide specifically mental health care. So that would be our second rotation, and bringing in a little wider sample to see how it responded in a little wider group of people and the providers. And the ultimate goal is to continue to add providers and providers and providers with each cycle, and to be able to make modifications depending on those persons who are the providers and those persons involved in the interdisciplinary team, to be able to eventually have the entire student health center involved in this specific immediate treatment, and being able to teach our student patients to how to do this intervention. of diaphragmatic breathing so they can have immediate response to their anxiety while we're waiting again for further mental health care services to be available to them. And thank you for listening to that presentation. I'm open for questions now.